Hi, I'm Dr. Shumit Khoshal, consultant endocrinologist from Nightingale Hospital, India. On behalf of myself and my colleagues, Dr. Vinayak Sinha from AMRI Hospital, Kolkata, Dr. Rajiv Kobil from Mumbai is a consultant diabetologist, and Dr. Jignesh Ved. I'd like to present the heart failure with preserved ejection fraction pilot study done in Indian population of patients. We recruited near about 99 patients across from the three centers, one from Mumbai and two from Kolkata. The number seems small, but for a pilot project, it was okay because the reason we wanted to do this particular project was to find out whether the clinical variables that we normally record for our patients with type 2 diabetes can predict the risk of heart failure with preserved ejection fraction. We have known that this was the holy grail, the emperor preserved trial, because whether it's a beta blocker or diuretics, or it's the mineralocorticoid receptor antagonists, they have all just had been effective in the patients with heart failure with reduced ejection fraction. We did not have outcomes changing molecule when it comes to heart failure with preserved ejection fraction. And the first molecule to do so was empagliflozin. Now, the issue is a large number of these patients will present with non-specific symptoms like pedal edema or some breathlessness. And the diagnostic tools to arrive at a diagnosis, either as a screening tool with high specificity like NT-proBNP, which is extremely expensive in a pay-per-pocket scenario like in our country, or doing an echocardiography where we need to understand the fluid dynamics within the heart, the transmitral blood flow and what is happening to those dynamics and parameters. It's practically impossible for a physician to arrive at a diagnosis by using these two tools. And hence, it again comes and falls into the domain of a cardiologist. But for a disease which is not as explosive as at presentation as heart failure with preserved ejection fraction, we thought that it's better if we can identify some clinical parameters by which we can identify those at high risk for heart failure with preserved ejection fraction. And with that aim, we just collected the data of all the variables that we normally collect for patients with type 2 diabetes. Now, what we see from, which is extremely important also to note that although we do not give that importance to heart failure with preserved ejection fraction, which it traditionally was thought to be a diastolic dysfunction, but today we know it's not that simple. We can also have systolic dysfunction associated with it. And in the backdrop, we can also have around 50% of patients the established atherosclerotic cardiovascular disease, but another half, it might be without the atherosclerotic cardiovascular disease. And its mortality rate is as bad as that of heart failure with reduced ejection fraction. Hence, identifying this population is extremely important. So this is a real world descriptive analysis that we had conducted. So cross-section analysis was done using patient medical records. And what we found from this patient medical record was that most of these patients presented with or were diagnosed with heart failure with preserved ejection fraction, which we followed the ESC guideline of ruling out anemia, ruling out medications which are known to cause fetal edema, and ruling away hypothyroidism, and then screening with NT-proBNP and going ahead with echocardiography. And these are all diagnosed patients with type 2 diabetes and heart failure with preserved ejection fraction. Our key findings are put up in the summary, but if I can just go through it, what we find is that out of every 10 patients who are diagnosed with heart failure with preserved ejection fraction, at least 2 were less than 60 years of age. So it's not necessarily that we'll be expecting this entity only in the elderly population, but also in middle-aged population. About one of our patients had 1 out of 20 had atrial fibrillation. At least 4 were not obese. So we're expecting a quarter of a patient who will not be obese and might have the heart failure with preserved ejection fraction. At least 2 of patients, or 20% of the patients, had low NT-proBNP. So as we always use NT-proBNP as a test which is used as screening, having a high specificity, we should not include it as a test of high sensitivity. Otherwise, these were the patients whom we will lose who fail to diagnose as heart failure with preserved ejection fraction. The most important factor was the presence of CKD, either an eGFR less than 60 or overt albuminuria. So 7 out of this 10 patients with heart failure with preserved ejection fraction had some form of CKD. So this is a very strong pointer, apart from obesity, for developing heart failure with preserved ejection fraction. And equally important, 8 out of 20 patients had, of 10 patients had uncontrolled hypertension despite having good metabolic control. This is another very, very important parameter. So effective management of heart failure, or whenever we are dealing with someone with resistant hypertension, some degree of overproteinuria, CKD, even if they have a normal NT-proBNP at screening, we see 6 out of 10 patients were non-obese. So these are the clinical parameters that we could identify based on which we can suspect a heart failure with preserved ejection fraction. And probably in this cost constraint scenario, if we can identify this subset of patients in the backdrop of type 2 diabetes, where sometimes doing both NT-proBNP as well as an echocardiography could be challenging from the cost perspective, we can straight away ask for an echo and understand whether the patient has heart failure with preserved ejection fraction. So we summarize that the premature onset of both cardiometabolic risk as well as heart failure with preserved ejection fraction is seen in, especially in the Indian patients of Indian ethnicity. Considerable prevalence of the atypical clinical manifestations are seen in heart failure with preserved ejection fraction, is not as typical as those with atherosclerotic cardiovascular disease. We need to identify them earlier and better control of hypertension, and early identification of CKD and management of CKD has to be instituted to prevent the development of the disease. Or if they have already developed this disease, then we have to screen aggressively to look for heart failure with preserved ejection fraction. So a high degree of clinical suspicion is required for this subset of patients. We'd like to thank IDF for giving us this opportunity to present our data. I'd like to thank Dr. Jignesh Fred for helping us to prepare this particular slide set. Thank you.